My name is Sonia Lievendorfer, and I am talking to healthcare providers today on changes that we need to make to our treatment regimen for our heart failure patients. 1 in 4 heart failure patients ends up readmitted to the hospital, and that is not a successful program. So we need to look at what we need to do to change things for our heart failure patients. First, I want to tell you a little bit about me and why I am so committed to heart failure in this patient population. I worked on the floor from 2003 to 2019, and I was either working in ICU or the emergency room. In my time in practice, there were two patient populations that I saw return to the emergency room all the time: diabetics and heart failure patients. Now, diabetics have their own educator that goes over their treatment plans with them. But we really don't have that for heart failure patients, at least where I live. I live in Columbus, which is the second largest city in Georgia, and you would think that we would have such an education program for our patients. The education program that we do have for our patients is geared for those who have only 35% ejection fraction or less. So there's a large volume of heart failure patients that aren't being served by the cardiac rehab program that we have established at our local cardiac hospital. My grandmother also died from heart failure. My master's program focused on heart failure because I started looking at why 1 in 4 patients is readmitted within 30 days. That's unacceptable. And it's been this way for 10 years. Why do we think this is okay? The main reason that I'm doing this is I'm hoping that this information that I'm putting forth in this presentation will get in the hands of the people that can make the difference. You can make the difference. If you get this in the hands of a hospital administrator, case manager, anyone who takes care of heart failure patients, yourself included, and start pushing to see that some of these changes are made, you'll see a difference in your readmission rates. Your hospital's financial status will improve because every time one of these patients gets readmitted within 30 days that they were discharged, that's lost income for the hospital because Medicare and Medicaid won't pay. And we're going to go into that during this presentation and why there needs to be a call to action to help these patients before they reach crisis stage and have to be readmitted. First, we need to look at some of the numbers. 6.5 million people in the United States have been diagnosed with heart failure. The prevalence of heart failure and the 5-year survival rate has increased due to changes in medications and treatments that they've come out with through the years. But each year, 1 million people are hospitalized in the United States due to heart failure. Despite the improvement in our therapies, our readmission rates remain high. 1 in 4 heart failure patients returns to the hospital for readmission within 30 days after being discharged. Now, heart failure patients themselves have identified 5 factors as reasons for being readmitted. Now, those are distressing symptoms, feeling that they cannot breathe, feeling that they're suffocating. When they reach a point that they cannot take in a deep breath, They have air hunger. They feel like they're suffocating in all of the fluid that they have on board. That causes a readmission. Whenever they have a heart attack or they have an intervention, pacemaker, defibrillator placed, that causes an injury to the heart. And that causes an unavoidable illness progression. Because whether they've had a heart attack, whether they've had a pacemaker placed, defibrillator placed, all of that stuff causes injury to the heart. And it ends up causing heart failure. And it causes heart failure because the heart is not the same. It's had a change to it. It's had an injury to it, even though it's been an intervention for the better in times of cardiac cath, stent placement, pacemaker placement. Still, the injury to the heart itself from the insult of having that procedure done can cause heart failure. Other things are psychosocial factors. If they have a lack of support system, if they don't have a family that is supportive of their diet regimen, if they don't have rides to their doctor's appointments, if they don't have the financial means to eat properly, and it's easier for them to eat fast food instead of cooking a well-prepared meal that is less in sodium, then all these are factors that go into how well they do once they leave the hospital. By their own admission, they say that they have problems with self-care because they're not ready to accept the diagnosis. And we're going to go into that because that's one of the focuses on my research, is dealing with these people that aren't ready to accept the diagnosis. And also health system failures. People that have a lack of insurance, which delays the needed care that they need. In a recent study of the heart failure patients said they thought that their readmission could have been avoided if they had more knowledge and adhered to their diet. Now, we're going to talk about this because I think there is a lot of information that is put out there as far as discharge planning instructions. But like I said in my first video, it's like we fill up a balloon with helium and then we release it out into the environment and watch it float away. We don't have enough of a follow-up with this patient population. And I think that's one of the main reasons that people end up back in the hospital is improper follow-up. One of the things that they have indicated they have needed, and it's one of the 3 things that I covered in my video, is more knowledge. Now, by more knowledge, they are asking to understand the pathophysiology of heart failure. They're wanting a better understanding of what causes it. They're wanting a better understanding of why they have to reduce the sodium in their diet. They're wanting to know why they have to have fluid restrictions. They're wanting to know why they need to monitor their activity. All of these things come into play. And they're asking for this information, and we really need to have an advanced practice nurse or a cardiologist sit down with these patients in their home and see what barriers to success they're going to have in the home and explain to them about the pathophysiology of the disease because they're wanting this information. If you explain the why, they're more accepting of the changes they need to make. Now, we said in the beginning that despite the improvement in the therapies and the drugs and everything that we're doing for heart failure, the readmission rates remain high. So even though we're doing all of this teaching prior to discharge about diet, exercise, and adherence to taking the medications and reducing salt intake and reducing fluids when we need to, what have we really done to improve their care. Now, talking to them and educating them about the pathophysiology is one of the 3 things that I said needs to happen for this patient population. Okay, well, what have we done so far? Well, in 2009, the Centers for Medicare and Medicaid decided to start publicly reporting all of the readmission rates, and they started financially penalizing hospitals that had high readmission rates during the first 30 days after discharge. The heart failure patients are the ones that 10 years later still have 1 in 4 returning to the hospital within 30 days. All right, so we just, the Medicaid and Medicare program said, okay, we're going to take money away from you, hospitals, because you're not doing your job. People are coming back within 30 days, so we're not going to pay for those second visits when they come back in for the same reason. So hospitals started looking for what they could do to try to remedy this problem. So what they did was they adopted what was called the gold standard for indicating patient understanding of discharge instructions. They adopted a method called the teach back method. Now, when this method was adopted, when it was adopted by proposed by the National Quality Council, when it was adopted, our readmission rate was 26%. In the 10 years that this method has been used, our readmission rates have only gone down 1%. So our readmission rates are still 25%. That is unacceptable. We have got to start looking at different ways of taking care of these patients. So let's look at some of those. All right, well, let's look at the discharge planning team we have working in the hospital, shall we? We've got the cardiologist on that team. We've got the pharmacist on that team, social workers, physical rehab, recreational rehab, occupational rehab, dietitian. But I think there's a key player that's missing off of this team that needs to be there. You have any ideas who it is? Well, let's see what the research says. There's a key member missing. A key member missing from that discharge planning team, and it is a psychologist. Now, why in the world would you say a psychologist needs to be included on that team? Very easy. First of all, you need to know if that patient is even ready to learn about their illness. If they're not ready to learn about it and they're not ready to be accepting of the information that you're teaching them, you might as well be bouncing a rubber ball off a wall, because it's not going to sink in. They're not going to be accepting of it. Are they in denial about the changes that need to be made? If they're in denial, none of that teaching is going to get in. It's not going to sink in. They're not going to be receptive. You need to have a psychologist assess whether they're too depressed and don't care. If they're too depressed and don't care about what you have to say, that information that you're giving them, I don't care how thorough it is, it's not going to sink in, because they're not in a place that they're ready to learn about it. Not only that, they don't have the energy. They can't focus. They can't concentrate. They're not going to be receptive to what you have to say. What about anxiety? If they're anxious because they can't breathe, or they feel like they're suffocating, or they have air hunger because they just can't take a deep breath, they're not going to be able to focus on what you're saying. You can do all the teaching in the world, but it's not going to sink in. And a psychologist in the hospital can start to identify the barriers to success for that patient. The barriers to success, what are we talking about? Access to health care, access to medications, availability of a ride to get to appointments, availability of a ride to get to the store to buy what they need to eat properly. This is why it's important, and we're going to discuss this later on, to visit the patient in the home after discharge. So you can see barriers that that patient might not even identify themselves as a problem and address them. All right, so where did my idea of a psychologist come from? Came from Taiwan. Taiwan used a psychologist on their multidisciplinary team to prepare patients for discharge, and guess what? Patient readmissions went down to 10%. Now, I don't know about you, but that's a far cry from 25%, which is what our current number is. I think it might be worthwhile for the hospitals to consider adding a psychologist to their discharge planning team to make sure these patients are prepared and ready to learn about what they need to know to go home and take care of themselves properly. Because if we're not ensuring that they are processing the information that we're giving them and internalizing it, it's not going to do any good to send them home with it because they're not going to follow it. They don't have the desire to. All right, so other than a psychologist, what else has worked? Well, we've seen use of home visits by a nurse. We've seen case managers go in the home, try to identify the barriers to success and help them with rides and such as that. We've seen telephone support, 24 hours. They call them within 24 hours after they've been discharged, see how they're doing. We've seen telemonitoring for the home where they manage their vital signs and control their weight and monitor any changes day to day through telemonitoring. If they gain more than 5 pounds, they're instructed to call and let them know why. If they don't call them, then they usually call and find out if there's a problem with equipment, if it's not picking up properly, if it's not working, or if it's just a matter of, no, I didn't really stick to my diet yesterday. Maybe there's hidden sodium in the diet that they don't know about. All of this is a learning curve. But it is our responsibility to help them with that learning curve. Disease management clinics, such as what Emory has for their heart failure patients. The important takeaway is there are a lot of interventions that are available for heart failure patients. But individually, no one program has worked. It has taken a collaborative approach. And this should really come as no surprise because heart failure is a complex problem. It stands to reason that it would take a multidisciplinary approach. Okay, so we've talked about my first two things. Teaching the patient about the pathophysiology and adding a psychologist to that discharge planning team to make sure that patient is ready to learn what they need to do to take care of themselves. Now, we have all heard of the term holistic care, and that means not just taking care of the patient, but considering the environment that that patient is in and how that environment affects that patient and affects their success. And that's where the third component comes in. We need to have transition teams that follow that patient once they leave the hospital, go into the home, see where they live, see how they live, and determine what barriers they have to their success. Do they have transportation? Do they have their medications set up in a way that they'll remember to take them? Do they have a cognitive decline, so they have problems remembering medications? Do they have a family support to help them with their diet, or are they on their own? All of these things have to be taken into consideration and more. And a lot of times barriers won't be identified until you get in that home and see for yourself what that person is dealing with every day. Now, when we talk about transition teams, these are teams that go in the home after the patient is discharged, considering an advanced practice nurse, a regular registered nurse, physical therapists, occupational therapists, people to transport them to and from appointments if they need it, a case manager to make sure everything is lined up for them as to what they need, a pharmacist to go through their medications and make sure that there's nothing in there that's going to interact. All these are important, but it's important to follow up with them at home. Now, Emory uses these teams, and I'm using Emory because I'm from Georgia and I'm familiar more with Georgia than anywhere else in the country. But Emory uses transition teams for new hires. When they have new nurses come on board, they don't want them to feel overwhelmed. So they pair them up with seasoned nurses, and they make sure that they have the guidance that they need until they feel comfortable. The same thing needs to be done for heart failure patients. Why? Because their care is so complex and it's multifaceted. It's not just looking at medications. It's not just looking at diet. It's not just looking at exercise regimen. It's looking at the whole picture, including their environment, where they live, what constraints they have. Now, there are 8 things that you need to look at when using a team approach for discharging a patient. The pharmacist, the cardiologist, the rehab people, physical rehab, occupational rehab, everybody needs to work as a team, have clear communication, have goals and outcomes outlined, work together as a team, provide the patient with timely, clear, and organized information. But that's going to be based on what? Their readiness to learn, which really should be assessed by who? A psychologist. Then you also have to go over their medications, reconcile them against what they've already been taking, make sure you don't have any that are duplicates, make sure you don't have any that are going to interact. All of that becomes a very important factor as you're getting ready to discharge this patient. Now, the other thing that we need to do is to make sure that we have these people set up with social groups and support groups to make sure that they don't feel like that they're being just left out there with no support. Because what do you think the likelihood is they're going to be going back to the hospital within 30 days if they have no support? probably more like 100% instead of 25% because they don't understand to begin with. You have to monitor these patients through telemonitoring. You have to support them through telephone calls and visits. You have to follow their signs and symptoms after discharge through telemonitoring or through home visits by a home care nurse. You have to follow them up and make sure they're going to their doctor's appointments like they're supposed to, especially people that don't have rides. And you have to make sure that you have advanced care planning and palliative care for when they get so bad off that it's not going to be much longer because their heart is totally getting to the point that it's failing. These are the references that I used in this presentation out of the 10 or 12 that I had in my original paper. If you want to look at the original research on this, I have it listed under Academia EDU under my name, Sonia Liebendorfer. There is a paper there on congestive heart failure that contains all of my research on this subject. If you have the time, I urge you to go and check out my original paper. In detail, it outlines all of the changes that we need to make for our patients with regard to heart failure. This is just a brief synopsis of that paper, outlining the need for a psychologist to be added to the discharge planning team to determine readiness to learn, the teaching of the pathophysiology to the patient to make sure that they understand the why of the changes they need to make, and third, hospitals need to commit to the use of transition teams. 1 out of every 4 patients that they send home, 1 out of every 4 that has heart failure returns within 30 days. That's lost income because of improper care, according to Medicare and Medicaid, from not being taken care of properly the first time. If you want to recoup that income, implement a transition team to go to that patient's home and see how they live and see what their barriers are to success, and then formulate a plan accordingly to keep them in the home and out of the hospital by having early interventions through that team whenever there are problems. Together, we can turn this around and we can make these outcomes better for these patients. But it's going to require effort and it's going to require changes. And yes, they may be painful at first, but you will see a difference in the health of your patients with reduced costs due to readmissions, and by investing the time and energy in teaching these patients how to take care of themselves properly, you will not have a continuous revolving door 1 out of 4 times that you send a patient home. So I implore you to accept this as a call to action to change our current practice. Thank you.